Thank you. Thank you, Rohit. At the outset, I would like to welcome all of you to this lovely city of Kolkata, and thank you for making it here. And I would be talking to you about retained smile lenticule. Now, as far as the problems during lenticule extraction are concerned, they vary from 2 to 9%, and lenticule extraction may be difficult due to incomplete photo disruption, especially in the hands of novice refractive surgeons. If the lenticule is retrieved successfully, there is no impact on the visual outcomes, but if there is retention of the part of the lenticule, then this may result in the interface haze and may cause refractive surprises. So the retained lenticule in smile could be completely retained, or you could have just partial lenticular fragments which could be retained. Now, just to show some problems which can occur, especially such as in this case, this is a case where the smile lenticule is retained, and actually the anterior plane, you actually entered into the posterior plane. So if the air does inadvertently enter in the area between where the dissection has occurred and it has not occurred, you can actually delineate and then see it, and this can guide you to do a correct dissection in the correct plane. Now, there can be problems during the procedure, and that may also cause incomplete dissection of the smile lenticule. For instance, here you can see that there are some dark spots which are present here, and those dark spots, if you don't separate before you actually pull it out with the help of the forceps, you can see that there are stria here, and obviously it has not separated from here. Then this part may be retained if this is forcefully pulled out. So it is best to actually, with the help of lamellar dissector, separate it completely and then pull it out with the forceps to prevent this inadvertent lenticular fragment which may remain behind. Now, when you have opaque bubble layer, such as in this case, then actually the dissection may become difficult, and again there may be macro adhesions which may be present, and by the proprioception you can make out that it has not dissected well in that area, and every attempt should be made to dissect it completely so that there are no inadvertent remnants or tags which remain behind. This is again what I showed you earlier, a difficult dissection where if air does go inadvertently, at times it doesn't go inadvertently, then you try to see that it does, so that you can see the edge which is there and completely dissect it again, as has been shown here. So a completely retained lenticule, I think, is still easier to tackle with. It can be detected on the table if you have an intraop OCT microscope. If you don't, then you can shift the patient to the anterior segment OCT. And then Sinskey hook can also be used to rescue in the cap lenticular adhesion. You can peel off the lenticule from the cap. Alternatively, circle software can be used from cap to flap to peel off the lenticule. Another option which is there is that you could abandon the case, and this can occur especially if the cornea has become edematous because of your excessive needling into the or excessive attempt to remove it. And then one can do a retreatment at a later date using a cornea ablative procedure such as a PRK or LASIK, or else one can again, in this eventuality, also use a circle software cap to flap followed by examined laser ablation and then try to peel off the lenticule. I think the partially retained fragments are a little more challenging. Again, they can be detected on the table. On the table, you can detect it on the intraop OCT microscope if you have it. People have alternatively used trypan blue dye and tremesolon and try to remove it with the forceps, and sometimes even hydrate it out so that you can pull it after hydrating it, or do a customized ablation at a later date. Partially retained lenticule fragments do lead to irregular outcomes and can impact the visual acuity, and there may be increased higher order aberrations subsequently, and the long-term visual outcomes may be suboptimal. This is our publication from the center where we did in the beginning, when we were still in the learning curve, use anterior segment OCT as a rescue tool during difficult lenticule extraction in smile, and this can be done. Only thing is that you will have to abort the procedure for that particular time and then take the patient to anterior segment OCT and then see and get the patient back and then remove the retained lenticule. And this is Dr. Ramamurthy's technique of using triamcinolone acetonide for eminent lenticule identification in SMILE. Dr. Sheetal has very nicely highlighted two cases how Circle software for management of retained lenticule tissue was used. Now, this was our case in which there was a retained lenticule, and intraoperatively there was some experience in the lenticule extraction which resulted in prolonged tissue handling, and it became hazy, the cornea became hazy and edematous. So instead of abandoning the procedure, it was decided to shift the patient under surgical microscope to intraop OCT microscope, and under the intraop OCT microscope the posterior lamellar plane was highly reflective and compared to the anterior lamellar plane, and so you can actually make out which part is the one which is dissected. So the part which is highly reflective will tell you that this part has already been separated, and under direct visualization of intraop OCT microscope the peripheral edge of the adherent lenticule is separated, and then subsequently it does become easier, and also if it gets any difficult on the IOCT itself, you can see the hyperreflective area upon dissection, and also this can delineate the planes of dissection in a much more quantifiable manner. The free edge of the lenticule then, with the help of the microforceps, can be grasped and extracted using the continuous curvilinear sort of a lenticulorhexis procedure, and the procedure can be completed without any problem. So we've found this to be very useful. The only problem is that our both the machines are at different floors, so we have to actually shift the patient from one floor to the other because intraop OCT microscope is not placed in the same floor. But the current machines have intraop OCT microscope integrated into the lenticular platforms, and I think that is the way to go, especially when we all have shifted almost to the lenticular surgeries. So this was published as a new technique how IOCT can be used as a useful tool, not only for complicated cases but also routinely this can be used, and this was published way back in 2017 by our group. So to conclude, it is possible to manage. You can have retained lenticules more so in your learning curve or when you are beginning to learn SMILE, but it is possible to manage it, and you can manage it either intraoperatively at the same time or you can do it at a later date. Thank you very much for your kind attention.
Thank you, ma'am. But one of the biggest strength of the SMILE platform is the ability of it to give you rescue machines. These, when you have a suction loss, when you have a large black spots, and that's one thing which is a very big plus factor when somebody's learning these procedures.
Yeah, I agree. I mean, that is definitely there.
Any other questions?